Hello, this is BIOC211, Lecture 22 Part 2, and we're looking at cardiovascular system disorders. So today we're going to be looking at diseases of the endocardium, the myocardium, and the pericardium. Let's start with infective endocarditis. So the prevalence of this is about 2 to 5 cases in 100,000 people, and that's in the United Kingdom. There's different time frames for the incubation period. If it's bacterial driven, it's about 2 weeks. If it is candida driven, it's about 5 months. So the pathophysiology is interesting with infective endocarditis. Firstly, I want to talk about these characteristic lesions that are seen with infective endocarditis, and they're called vegetations. So basically the pathophysiology is that after that initial adherence of the bacteria becomes encased in a platelet fibrin matrix, and that's called the vegetation. So the formation of this vegetation is likely initiated through the release of tissue factor, so thromboplastin is that tissue factor, and that's caused from the damaged endothelium. That causes platelet activation and aggregation, cleavage of fibrinogen to fibrin by thrombin. So there's a lot of that clotting that's going on here. So in severe cases, the vegetations can cause obstructive damage of the cardiac valves. That can lead to systemic embolization, congestive heart failure, or possibly even the need for prosthetic valve replacement. The etiology of infective endocarditis. This is a microbial infection of the heart valve, the endocardium, the lining of the blood vessel, or congenital anomaly of the heart. So as I mentioned, there's a number of causal organisms, so usually bacteria, but it can also be a fungus or a chlamydia or a rickettsia. So they're a spirochete. Now, risk factors. There can be local cardiac risk factors, so valve lesions and prosthetic valves, also factors that can cause bacteremia. So we've talked about IV administration, cannulas, those sorts of things. It can be iatrogenic, so post-surgery, post-medical intervention, dental. Also, there's a number of different organisms, so strep or staph. There can be often the complications are due to IV drug misuse. About 3/4 of the bacterial, or 3/4 of cases are due to strep sanguis or staph infections, and other organisms that are indicated are Enterococcus faecalis, Enterococcus faecalum, and strep bovis. Subacute endocarditis clinical features. So we'll often see persistent fevers, tiredness, sweating at night, and congenital or valvular heart disease. So you can also see purpura or petechial hemorrhages. So these are these various size purple spots on the skin that are caused by broken capillaries. You can see there can be a palpable spleen. So the spleen is swollen enough that you can actually feel it. I'm over here feeling my liver, but it's actually the spleen's over here on the left. And late stage clubbing, so that's clubbing of the fingers that's seen in late stage of the disease. With acute endocarditis, this can be a severe febrile illness, a changing murmur, petechia. Again, those are the purple spots. You can also see embolic events. These are quite common, so that can be cardiac or renal. And post-op endocarditis, this is unexplained fever after heart valve surgery. You can see quite high morbidity and mortality rates with this. And endocarditis often occurs in old age. So with this, you'll see confusion, weight loss, malaise, weakness. And one of the common causes of that is Enterococcus or strep bovis. And once again, there's a high morbidity and mortality with that. So here's an image of various presentations of the signs and symptoms of infective endocarditis. Have a little read through this. You can see there's the spleen, splenomegaly, swollen spleen. You can see that clubbing, splinter hemorrhages. We've talked about those. See the little brown stripes? We spoke about those in the kidney lectures. So have a look through those. Okay, so investigations for infective endocarditis, blood cultures, ECG, echocardiography, chest x-ray. So now I wanted to talk to you a bit about the diagnosis method or what sort of criteria they need to look at. So this diagnosis of infective endocarditis is called the modified Duke criteria. And there's major and minor criteria. So they need to have a positive blood culture, there needs to be endocardial involvement, and then the minor criteria are predisposing valvular or cardiac abnormality, intravenous drug use, pyrexia, so a temperature above 38 degrees. There can be embolus, blood cultures suggestive of an organism growing, and suggestive echocardiographic findings. So go and have a look at that. Just search for the modified Duke criteria and infective endocarditis, and it will give you all of the details of that. Now, treatment. So empirical treatment methods depends on the mode of the presentation. So what kind of organism it is, whether the patient has a prosthetic valve or a penicillin allergy, etc. So, for example, if their presentation was acute, they may give certain types of penicillin, such as gentamicin, and for subacute presentation, they may give benzoyl, penicillin, and gentamicin. If people have a penicillin allergy, then they would need to, or if they suspect methicillin-resistant staph, or they have a prosthetic valve, then they would be looking at triple therapy with a variety of antibiotics. Okay, so it can be prolonged and difficult. Surgery may be indicated, and obviously there needs to be prophylaxis for valve lesions. And this condition is fatal in about 20%, so it's quite a high fatality rate. Where are we? So acute myocarditis. The definition of acute myocarditis is an acute inflammatory condition that may complicate a wide variety of infections. So inflammation may be due to infection of the myocardium or the effects of circulating toxins. Now, viral infection is the most common cause, and the main culprits of these viral infection are Coxsackie viruses. That's about 35 cases per 1,000 infections, and influenza viruses A and B cause about 25 cases per 1,000 infections. Myocarditis can actually occur several weeks after the initial viral infection, and that susceptibility is increased by corticosteroid treatment, immunosuppression, radiation, and when people have had previous myocardial damage. Also, exercise can put you at a predisposition for myocarditis, which is a bit scary. Don't want you to stop exercising because of that. Some bacterial and protozoal infections can be complicated by myocarditis. So, for example, approximately 5% of patients with Lyme disease, so Borrelia burgdorferi, sorry, I said that wrong, they develop myopericarditis, and that's often associated with variable degrees of atrioventricular block. Occasionally, it's also associated with systemic lupus erythematosus or rheumatoid arthritis. So these clinical features can present with either no symptoms, they can be similar to flu, or they can also present as heart failure. The biochemical markers will be those of myocardial injury. So you're looking at troponin I and T and creatine kinase. So these are elevated in proportion to the amount of damage that's been done to the myocardium. Echocardiography can show left ventricular dysfunction, and that's sometimes regional due to focal myocarditis. And if that diagnosis is uncertain, it can be confirmed by endomyocardial biopsy. So here's an image on the left. You can see mononucleated white blood cells that are infiltrating that myocardial tissue. And on the right, you can see grossly inflamed left ventricular myocardium. That's indicated with that arrow. Investigation, so ECG and, as mentioned, those same biochemical markers of myocardial injury, so the troponin INT and creatine kinase. Treatment we're looking at, it can be non-specific, or you can look at specific antimicrobial treatment if you know what kind of microbe or pathogen is the cause. People should be avoiding intense physical exercise to take that load off the heart. Prognosis is generally good for myocarditis, but as it mentioned there, it does depend on the cause. Now, the definition for cardiomyopathy, this is a general term that is used to describe diseases of the cardiac muscle. There are a number of classes here of cardiomyopathy. So dilated cardiomyopathy, this is dilation and impaired contraction of the left ventricle, but there's no increase in wall thickness. With restrictive cardiomyopathy, this is rare. It's when you see impaired ventricular filling because the ventricles are stiff. And then the hypertrophic cardiomyopathy, this is the one you see the most often, and we have talked about this a number of times so far. But left ventricular hypertrophy is the most common one, and this can be generalized or confined. So the causes, most of them are idiopathic. We have talked about that left ventricular hypertrophy with people who are athletes. There can be a lot of other causes as listed here, so genetic, endocrine, inflammation-related, nutritional. Most of these cases of the hypertrophic cardiomyopathy are inherited, and there have been about 50 mutations that have been linked to this condition. So clinical features of cardiomyopathy: angina on effort, dyspnea on effort, so that's that difficulty breathing, syncope on effort, sudden death is obviously one of those. So other signs can be a jerky pulse, palpable left ventricular hypertrophy, so you can actually feel it, that the heart is that enlarged, double impulse at the apex or a palpable fourth heart sound due to the left atrial hypertrophy. There can be a mid-systolic murmur at the base, and a pansystolic murmur due to mitral regurgitation at the apex. And obviously those terms are related to auscultation, listening through a stethoscope. So investigations, the ECG is usually abnormal, and it can show features of left ventricular hypertrophy. So we've looked at some of those, but it can also have a really wide array of quite bizarre abnormalities. So there's a few of those. So it can be things like a pseudo-infarct pattern and a deep T-wave inversion. So echocardiography is usually diagnostic, but that diagnostic can also be difficult when there's another cause of that left ventricular hypertrophy. So that physical training with that, like an athlete's heart, that can predispose someone already has that left ventricular hypertrophy, that may impair your ability to diagnose the cardiomyopathy if it's been caused by something else. Genetic testing can, of course, facilitate diagnosis, but that's probably going to be the case further down the track in the future. So treatment for cardiomyopathy, we're looking at beta blockers, rate-limiting calcium antagonists. Disopyramide is a medication that can help to relieve symptoms and sometimes prevent fainting, syncopal attacks. Imidodrone, that can help stabilise arrhythmias. We've spoken about that before. It can also stabilise outflow tract obstruction and can be improved. That can be improved by partial surgical resection, so myectomy. Implantable cardiac defibrillator for patients at risk of sudden cardiac death is also an option. Digoxin and vasodilators should definitely be avoided because they can increase outflow tract obstruction. So the prognosis for cardiomyopathy is generally poor, and it's really important to consider other differential diagnosis. So there are a number of other risk factors for sudden death in hypertrophic cardiomyopathy. So here are some of those. A history of previous cardiac arrest or sustained ventricular tachycardia, recurrent syncope, also an adverse genotype or family history, exercise-induced hypotension, so when people's blood pressure drops when they exercise, also multiple episodes of non-sustained ventricular tachycardia, so that heartbeat is racing, and that's on ECG monitoring, of course. Also marked increase in that left ventricular wall thickness is another risk factor for sudden death. Okay, acute pericarditis. So pericardial inflammation can be due to infection. It can be due to immunological reactions, trauma, neoplasm, And sometimes there can be no explanation for why that pericardium is inflamed. Pericarditis and myocarditis often coexist, and all forms of pericarditis may produce a pericardial effusion, which, depending on the etiology, can be fibrinous, serous, hemorrhagic, or purulent. So that's obviously the type of discharges that we've spoken about. So that can be part of that effusion. Less common causes of acute pericarditis are uremia, malignant disease, connective tissue diseases, so things like systemic lupus erythematosus, trauma, so blunt chest or crushing injuries can be a precursor to this. Other rare causes are bacterial infections, tuberculosis, and rheumatic fever. Acute pericarditis clinical features. So the characteristic pain of pericarditis is retrosternal, and it radiates to the shoulders and the neck, and it's typically aggravated by deep breathing, by movement, by change in position. Exercise generally aggravates, and swallowing can be aggravating as well. It's quite common to have a low-grade fever, a pericardial friction rub. So this is a high-pitched superficial scratching or crunching noise that's produced by the movement of that inflamed pericardium, and that is diagnostic of pericarditis. It's usually heard on systole, but it can also be audible on diastole, and frequently has what's known as a to and fro quality, and I know I've mentioned that before. So investigations for acute pericarditis, we're looking at ECGs. This is looking for ST elevation. It's looking at PR interval depression, also T-wave inversion, and that can be particularly affected with a higher degree of when there's a degree of myocarditis as well. Treatment. So the pain's usually relieved by aspirin. There are more potent anti-inflammatory drugs that may be required if the pain is more severe. Corticosteroids can suppress symptoms, but there's no evidence that they actually cure the problem completely. So viral pericarditis recovery, that usually occurs within a few days or weeks, but there can be recurrences, so you can get chronic relapsing pericarditis. Also purulent pericarditis, and this requires treatment with antimicrobial therapy and, if necessary, surgical drainage. Okay, this is pericardial effusion, and this is a build-up of fluid in the pericardial sac. So ways of diagnosing this or investigating this are serial chest x-rays, so they need to be done in short succession. So this can show a rapid increase in the size of that cardiac shadow over days or even hours. So with a cardiac shadow or silhouette, this refers to that visible portion of the heart that's in a processed chest ray or an imaging scan. Now, cardiac tamponade, this is a term that's used to describe acute heart failure due to the compression of the heart by a large, rapidly developing effusion. Treatment, aspiration. So this is when a needle is inserted under echo guidance, and it will be inserted medial to the apex or below the xiphoid process. So that's that lower area of your sternum, right just above your solar plexus there. And that's they direct that upwards towards the left shoulder. And they may only need to aspirate a few mils to diagnose, but they need to drain it to provide relief for that individual. Here's a video to have a watch of looking at cardiac pathologies. This is looking at rheumatic fever, which I know we've already talked about, but maybe go and have a little watch of this and join me shortly for the next screencast.